Physicians nodding, so that's good. Right, so on to the main event. We've got the three wise men to come and speak to us about acute intervention in acute stroke. I've known Alex for a long time, and he's a much better runner than I am, and winning races all over the place. But he prefers the longer distances, he tells me. And he's going to talk to us, I think, about the evolution of acute stroke services. And then we're going to hear from Graham Houston, who I don't know if he's a runner or a cyclist or not, but I'm sure he'll let me know. And he's going to talk about the radiological issues involved in managing acute stroke. And John Irving, who had the misfortune of spending days with me climbing up Archie Mountains for the Archie Mountain Challenge in the summer, is going to finish things off by giving us an overview of the interventional aspects that can be translated from cardiology into acute stroke. Well, I hope that's what they're talking about anyway. So I'll hand straight over to Alex, who'll start the ball rolling. Do you want to take questions individually, guys, or you want to take questions at the end?
I think probably at the end as a kind of discussion.
Panel discussion at the end, then.
I think everything will be. Does that sound about right?
Okay, thank you very much. So I was looking at this data. I'm going to present an interesting case that we had in acute stroke, and then take you through some of the emerging evidence for how acute strokes can be treated. And as I was going through this, I realized that it was actually quite topical in the sense that it was a very good Christmas story as well. So you'll hear a bit more about that. So essentially, we're going to talk today between us about how stroke services are probably going to evolve and must evolve in the coming few years, and the challenge that we will have as service providers to achieve that. So case-based discussion, first of all. This young woman, 38-year-old, she was healthy, she was no previous vascular risk factors at all. She was pregnant, 10 weeks pregnant, and she already had one young child. And she had a family history of protein C deficiency, and I can't remember whether that's relevant or not. On Thursday, the 20th of December 2012, she awoke at 9 o'clock with a left hemiparesis, and her husband called 999, and she was whizzed into the emergency department here by the Scottish Ambulance Service. But her symptoms were resolving at this stage, so they were getting better. And when she arrived at the ED, she was almost symptom-free. However, suddenly she developed these symptoms again, a recrudescence of the symptoms, a dense left hemiparesis. She had arm, face weakness and numbness. She had a left homonymous hemianopia, left-sided inattention, dysarthria. So altogether, this was a major non-dominant hemisphere, total anterior circulation, threatened infarction. In other words, the entire distribution of the right middle cerebral artery was being threatened with infarction. She had a very high NIHSS score, 19. That is a very bad prognosis. So the brain attack, I think everyone in the hospital now knows that we have a brain attack. There are some emerging developments, retrograde developments, I would say, on that. And she was seen by the stroke team, who headed to the CT, and she was scanned at 20 past 10, about T plus 45 minutes from the onset of symptoms. So very, very rapid. And this was her scan. And this is typical of the sorts of scans that we see in acute events. And you can just see here, I hope, if it's transmitting well, a hyperdense middle cerebral artery in the right-hand side. So this is the clot sitting there in the right middle cerebral artery, essentially blocking that entire artery. It's one of the main blood vessels in the brain. And if we take a slightly different slice, this is again typical. If it's projecting well, there's some loss of white-grey matter differentiation, or rather loss of basal ganglia differentiation there on the right-hand side, and the insular ribbon is not distinct compared with the insular on the other side. So very, very early signs of threatened brain. And that's what you'd expect given the presentation, so entirely in keeping with the neurological presentation. So this was essentially a wake-up event, but it had been fluctuating. And because we could see some very, very early changes on the scan that didn't necessarily fit with the entirety of her neurological presentation, we knew that there was a large clinical penumbra. In other words, a lot more neurology going on and a big neurological deficit in comparison to the very small area of deficit that we could see on the CT scan. So she was someone who we felt could be thrombolized, and with some very quick Googling and chatting with obstetricians, we decided that at 10 weeks pregnant it would probably be okay. It's one of these difficult decision-making processes, and we all agreed that we would do that. So she was thrombolized and transferred to our acute stroke unit. The thrombolytic takes about an hour to run through, and unfortunately, at the end of that hour, using transcranial Doppler ultrasound, which is a technique that we have access to in the acute stroke unit, we can insunate the artery, and we could see that, unfortunately, the artery hadn't recanalized. This isn't her pictures, by the way, this is just a demonstration. But I could see that there was no flow, unfortunately, in that right middle cerebral artery, so that brain was continuing to infarct. Very, very poor prognosis associated with that. So, progressively, very large area of infarcting brain. It was happening in front of us, and for that there's a very, very poor prognosis of a good outcome. And potentially with a young, healthy brain, with that amount of brain suddenly being affected, the possibility of a malignant middle cerebral artery syndrome, which is a large amount of swelling, and the concomitant damage of all of that happening in the brain as well. And above all, she's a young mother, she's expecting a baby, and it's nearly Christmas time. How do we restore the flow, and how do we rescue this situation? So what you need to do is find an interventional neuroradiologist or anyone else who can extract the clot and perform brain reperfusion in terms of rescue. So you get on the phone, you have to find one of these individuals who can do this in the right environment. You also need an anaesthetist, someone who is able to at least render the patient who's going to be slightly confused about all of these things happening to them in a way that the operation or the intervention can take place safely and effectively. So this all needs to be primed. And of course, time is running out, and these people aren't necessarily where you are, so you also have to arrange an ambulance. And all this has to be done in an extremely time-critical manner. So we got her to Edinburgh very, very quickly. It took about an hour and 20 minutes to get her from the acute stroke unit to Edinburgh, but there was about an hour on the phone getting all of these things worked out. And this is imaging courtesy of Peter Keston in the Western, who is the interventional neuroradiologist who very kindly agreed to take on this case absolutely out of the blue in his working day, not scheduled at all. So this is the first angiogram, and I'm very mindful I've got Graham Houston here who's watching, but this initial flow here demonstrates absolutely no flow in the right middle cerebral artery. So we know that things are blocked, and you can just about see the catheter going up here. And this is a slightly later phase, again, the entire right middle cerebral artery territory not perfusing as we go through these phases. However, as a result of intervention using this particular catheter-based device, the clot was pulled out, and here we can see flow restored in the right middle cerebral artery, and a nice flush of blood now reperfusing the brain. Beautiful. So very successful. Technically a good result. She went from the catheter lab into the intensive care unit in the Western, and then the following morning she returned to our unit with an excellent recovery. She walked back into the ward herself. The NIHSS score was now 0, essentially no neurological sequelae at all. She was, to all intents and purposes, completely better, and we discharged her home to family on Christmas Eve. It was a fantastic thing. We were all really celebrating. She did have a follow-up MRI, in fact, just before she went home, and it does show, unfortunately, there was an area of permanently infarcted brain. It's about one of the best areas you could choose if you had to choose an area of having some permanently damaged brain. But in a young woman of her age and her health, the prognosis for this was very good. So on formal testing, cognitively, you would have been able to have picked up some of these features, but it had a minimal impact on her life. So that was what happened with that woman, and that's really what this talk is all about: is how do we do this, and what's the evidence behind it. So that all took place in 2012, and essentially this is the issue. You have this area of brain which is being perfused. It's part of the brain that is creating your reality as you're watching me and I'm watching you. It's happening on the fly all the time, and if you lose a part of the flow to that brain, you instantly lose everything that brain does, and it has a potentially huge impact on your life. And obviously we need to find a way to restore that. The only evidence base that we have for reperfusing brain until this year, in terms of good evidence, was intravenous TPA. And as you know, it's limited to in its use in terms of timing, less than 4.5 hours from the time of onset to symptoms. It's not so good for large proximal clots, in other words, big clots like this young woman had at the proximal end of the middle cerebral artery. And overall canalization rates are very slow. And if you think about it, it's really this sort of problem: a blocked sink, and you're simply pouring a drain blocker onto that. It's not really going to have a good impact in terms of really unblocking the sink. And what you need is something like this to actually get down the hole and unplug and unblock the blockage. So endovascular therapy, that approach is very attractive because it's an alternative, additional, adjunctive therapy to the therapies that we already have. You can perform it in addition to intravenous thrombolysis, and potentially it is a therapy that's suitable for people who, for other reasons, aren't suitable for intravenous thrombolysis, such as people with high bleeding risk, etc. So, for instance, on warfarin, which is going to be a very big issue for people delivering this service in the future. So there is evidence, and until 2013, most interventionists were very, very gung-ho about this procedure, because if you see it happening and you're doing it, you immediately see the obvious benefit for people in whom it's successful. But of course, you need to get good evidence to ensure that it's going to work for everyone. And unfortunately, in 2013, a year after we did this to this young woman, there was this back-to-back series of papers in the New England Journal which unfortunately demonstrated that this procedure didn't seem to be evidence-based, and they were negative trials. So a lot of concern about the future at that stage, and a lot of hand-wringing. But everyone who was involved in these trials, the interventionists, the people who knew what they were doing, realized that the techniques that were used in those early trials had been not up to date. They had been old-fashioned extractor devices like this. This is the Mercy retriever, and various other devices that didn't work as well. And everybody knew that some of the newer devices were better at pulling out these clots. So there was some fundamental problems with the evidence base, and also imaging-based selection of patients had also improved in ensuring that we had good selection of getting the right patient into the cath lab to ensure that they benefited. So this is some of the imaging techniques that help in stratifying patients who are going to benefit. CT angiography is fairly straightforward. It does require some expertise in being able to interpret this, but if you're an expert who's involved in thrombectomy, you are good at looking at brains and blood vessels anyway. So CT angiography, you can improve on CT angiography by doing multi-phase CT angiography. And then there are some other more technical methods of performing imaging, such as perfusion CT, which looks at the mismatch between blood flow and threatened brain and already infarcted brain, and DWI, PWI, MRI. There's something that is extremely good under these circumstances, but for various reasons very challenging to get these acute patients into an MRI scan of 24 hours, 365 days of the year. So although MRI would be the methodology of choice, for various reasons it's technically not so easy. But certainly multi-phase CT is something that can be done on all scanners that we have access to. So I'm just going to show you this quick video which shows how the new stent retrievers work.
Position the balloon guide catheter as close to the thrombus site as possible.
Is that loud enough?
Connect a rotating hemostatic valve, or RHV, to the fitting of the guide catheter, and then connect the continuous flush. With the aid of a suitable guide wire, hold the guide wire in place and advance the microcatheter. Position the microcatheter distal to the thrombus so that the usable length portion of the solitaire FR will extend past each side of the thrombus when fully deployed. Once the microcatheter is in place, remove the guide wire and tighten the RHV to secure the catheter. With the aid of fluoroscopic imaging, carefully advance the solitaire FR until its distal markers line up at the end of the microcatheter. To deploy the solitaire FR, loosen the RHV. Then carefully withdraw the microcatheter while holding the solitaire FR in place until the microcatheter tip covers only the proximal marker of the device.
And the point is you get immediate perfusion at this stage.
The solitaire FR should extend past each side of the thrombus. Tighten the RHV around the microcatheter. Angiographically assess the revascularization status of the treated vessel. Inflate the balloon of the guide catheter to occlude the vessel. To retrieve thrombus, slowly withdraw the microcatheter and solitaire FR as a unit to the guide catheter tip while applying aspiration to the guide catheter.
Now, of course, that makes it look extremely simple, and it's not. And there are many, many technical issues involved, and people have to be extremely skilled to do that, especially to get the wire up into that little tiny part of the brain. But the important thing is these are developing all the time, the methodology is developing, and these catheters are getting into increasingly small areas of the brain, in fact, distal M2 section of the middle cerebral artery. So this is a summary of the new evidence that all came out in the New England Journal of this year. So it was very hot, off-the-press stuff, a whole series of trials. It was Mr. Clean that was one of the first, and as a result of the publication of Mr. Clean, which was performed in the Netherlands, there was all the other trials were terminated early because people felt that they were no longer in equipoise, and so there was a lot of these other trials subsequently terminated early and had an interim analysis and also proved that they were significantly beneficial as well. And this is one of the many recent meta-analyses demonstrating the odds ratio for improvement. This is just a very quick evidence summary. Overall, a 2.42 odds of improvement when using one of these devices, and that is on top of the already about odds of 2 in relation to thrombolytics. So you can add those two together if you're going to forgive some statistical juggling. There's a trend, though not significant, but you have to remember these trials were stopped early, so we don't have the numbers, but certainly a trend, at least not an increase or any evidence of increased mortality, and certainly no increase in bleeding, no statistical significance or any evidence that there's any increase in bleeding. So very, very good outcomes. There's a whole raft of concerns about still that this is only 633 patients and over 650 controls in total, and should you change the world with that amount of information? And people are mooting about the need to perhaps do some more pragmatic trials. Very importantly, and one should never show big slides like this, and I'm sorry, but essentially it's just to say that all the subgroup analyses across this meta-analysis suggest that pretty much everyone benefits if you're selecting people appropriately. So older people, younger people, men, women, very, very dense strokes, mild strokes, etc., etc., etc. So everyone seems to benefit. There doesn't seem to be any funniness going on there. So this data comes from world-class major centres in major cities with access to very, very large populations of people, highly trained, fast-moving teams with slick handovers. They do this very, very well. And the question is how do we translate that into this kind of environment? And there are some concerns about that, and Professor Houston is going to talk a lot more about that in terms of some of his presentation. But a point I'd like to make is that this is not dissimilar to where we were with thrombolytics, intravenous thrombolytics for acute stroke. Again, that data was produced by highly expert teams in large, well-resourced centres. And we had to get many, many individuals together working as a team, physicians, emergency medicine, radiologists, acute stroke nurses, all very time-dependently in this chain of events, right the way from recognition through to thrombolysis so many people involved in a very, very time-critical thing. And we know that this is the meta-analysis for benefit from the IV thrombolysis, and we can see that this rapidly tails off, and so all the benefit is in this very, very early stage here. And when you have a well-evolved team all working together, we, at least in Tayside and other places in Scotland, we've demonstrated over the years that we can also do this. So if you look at the mean onset to needle time in these very, very developed centres and studies, the mean onset to needle time was 119.7 minutes. And in Tayside, in 9 wells at least, 128 minutes. So we're 9 minutes behind with the teams. So this is Shoban from Accident and Emergency and a thrombolytic process going on. There are some challenges in Tayside, and again, we're going to hear more about that from Professor Houston. We are very distributed, large areas of very low density of population, and then these concentrations of high population densities. And how do we move people to areas of expertise? And looking at Tayside, about our size of population, we think, based on the number of candidates who would benefit from this treatment, about 1 a week, but that might be an overestimate in terms of the number. So we need to think about providing all of that at just once a week. But I think if we work together and we are creative about how we do it, there are tremendous potentials for doing that. And as you can see, here's Scotland now overtaking this faster team. Okay, so Graham's going to tell us about... Right, just do that. I think that's you there.
Does that mean the top of one? Thanks very much indeed, Alex, for setting the scene in relation to that. I'll see if I can get this thing to work. Where is the thing gone? So, one of the issues that we come along with, obviously, Alex has really defined very much the clinical problem, the potential benefits of this, the evidence base, and a very nice demonstration of the chain going from onset arrival, transfer, A&E, CT scan, thrombolysis, and then what? And just one point is that all the people that are being considered for clot intervention are going to have had thrombolysis already. So that's a starting point. So it's not everybody outside that box. So if we're looking at the people that wield catheters and we do this sort of thing across the hospital, one of the areas we start to think about is who potentially could do this area. In keeping with the kind of theme of the grand rounds, I'm going to put in some pretty completely disconnected pictures. So that for those of you who are in a pre-Christmas mood, if you're happy to switch off, then please do. I will ask you at the end where you think that picture is. So in terms of interventional radiologists, if I gave this talk when I started here 20 years ago, I would have to describe what I do in my day job, but I suspect probably that's come across now over the years. I think what it's fair to say is that we cover a lot of the body. One bit that's missing is obviously the head and neck, and that was a bit of an error on our part. And I think in a sense it was because the head was perceived as being a tiger country. Working in that area was particularly challenging in terms of end organ damage, and therefore it went into neuroradiology and neurointerventional radiologists' hands to do that. So the question we've got asked is can interventional radiologists do this on a wider scale, because there's many more of us around? And the answer to that question is quite clear, yes, because that's always the question that you say initially, or the answer to the question is always yes, but then you think, actually, there's a lot behind that. There's a lot behind that we'd have to look at, address, consider, and set up. But I do think if you do have an evidence base on a very, very common clinical problem, with clear benefits showing out through randomised trial data now, in good hands, then I think we should be trying to emulate those good results where we work. So let's look at some of the interventional radiologist skills. There are neuroradiologists working in specialist centres, we've got interventional radiologists, and we're going to hear a little bit about cardiologists and interventional cardiologists and what they do in that area too. But I think from interventional radiologists, there is a background of skills here. We do work from groin up towards the head. We do selective angiography. We block off things. We clot retrieve when we make mistakes down legs or elsewhere. And we do stent placement as a matter of routine. So endovascular techniques as a whole are very much our home yard. And in terms of caseload, we're doing many of these a year. We're doing probably around about 700 or 800 of these a year. Our facilities are good in terms of doing these procedures. The IR suite's good. We've got single plane fluoro in our units, but that doesn't seem to be a requirement that you necessarily need to go to two plane fluoro, although neuroradiologists like to work in that area. We have anaesthetic support, experienced interventional radiologists, nurses, and we have good patient monitoring. We're also, most importantly, quite used to working in multidisciplinary teams. So we're not working in isolation. So in terms of involvement on the diagnostic side with case selection, on CT reading and establishing the high-density clot or doing the CT angiogram as a team diagnostically and interventionally quite capable of that. Our transfer times from A&E through to the cath lab for trauma and for EVARs and GI hemorrhages are quite short. We're quite well set up for that. And our pre- and per- and post-procedure care are well supported. And obviously in terms of where we're currently aligned in terms of thrombolytic services, we have links through from A&E. We're part of that pathway already. I'm saying these things not really to say we're going to do it, but just to say that the setting's not too bad. But the question is really, where are the missing bits? And some of the missing bits is the sense of evidence of confidence that if you go beyond the neuroradiology centres and go out into the interventional radiology centres, can they produce the same results? And there's emerging evidence now from the Europeans' experience in relation to this, that in good centres, interventional radiologists can get equally good results to the neuro centres. Again, that's always, these are soapbox centres, if you like. They're the ones that are leading that side. So it may not be every centre that will achieve that. We are very aware of patient safety considerations of doing this sort of work. And the European body as a whole, missed that one, has basically come out with guidelines for people that are wanting to explore this area. So as a set of specialists, we're looking towards moving into this area in a steadily progressive and considered way. So that's one aspect to it. I think the bit that really you also have to look at is in terms of a national service and where we sit within that, there is a spread of cover. We talked about neuroradiologists, and they basically reside in Edinburgh and Glasgow, and I think currently I may be updated. There's probably only one in Glasgow and there's two in Edinburgh. It's kind of hard to imagine them covering a 7-day rota for a population of 6 million, and they're struggling to train. In terms of interventional radiologists, we have quite a lot of daytime cover with the black dots. And we have a 24/7 coverage in a number of centres. So there is a network here. And we'll see, I think, in relative to the cardiology experience, it's not as comprehensive as cardiology. But in terms of site position, geographically, it's not too bad. If, however, we come back to the slide at the beginning, that slide is out in the Battersea Beach in Barra. So it's quite a long way from anywhere, really. And I don't think for a moment we're going to be able to deliver the sort of time transfer times for those individuals. But we need to really look after what we can do across the central belt and up the east coast, bridging through to Inverness, I believe. So if we say that we have the general capacity in terms of sites, facilities, but we need to have more people and we need to train people who have currently not done interventional techniques into the head, we need to look at how we're going to train them. And the training aspects is really a skill extension of where we are currently. Head and neck catheterization, use of microcatheters, we use them down into the general abdominal area but not up into the head. Air embolus continuous perfusion is something we would develop further. Tips and tricks of how to get up into the neck vessels, probably no different than anywhere else in the body really, but you're just very cognizant of the fact you don't want to drop off little bits going off down the vessel further. Complication management, and most importantly I think when to stop. In my experience, when things have gone wrong, it's usually because I've just gone that little bit too far. So the enemy of perfect is basically good, or is it the other way around? So in other words, if you take it too far, then you need to know when to stop. The case selection is part of the armamentarium, and the procedure care we can also train. In terms of training, the Cusheri Skills Unit here, we've been working with them to look at the potential for training individuals, whether they be neuroradiologists that need to be upskilled, or cardiologists or interventional radiologists, looking at those skills extensions, looking at CT reading, procedure care, unconscious patient support, but particularly procedure training in terms of the use of simulators and we have an extensive experience of that. We've also been developing cadaveric models where we can simulate the whole OR or cath lab experience, and this is based on complete body perfusion using a heart-lung machine of cadaveric work, cadaver supplied by the anatomy department. And basically, in terms of an operating environment, it's exactly the same really as our day place. So it's a very good place to learn the skills, make the mistakes, and be able to talk it through with people who are training. And the benchtop device practice is probably a little bit limited in relation to this area. The mentoring and proctorship of people wanting to do this is also been discussed through with neuroradiologists. So in summary, there's basically, we're quite well placed, along with the cardiologists, I suspect, to try and consider this. You'd have to look at extending skills, training facilities, mentoring, proctorship, and most importantly, set standards for training and competency in this area. I think that's probably where we need to address that next. There's also a very, very big issue, which is logistics within a challenged healthcare system to try and provide more services. But I do believe in some senses we've got quite a lot of the infrastructure and support already in place. We wouldn't envisage setting up a standalone service for this and import new people in for 40 patients a year, but if you can use existing service delivery models and adapt them and take that beyond that, then I think that's certainly scope for that. So coming back to that beach, and basically I'm looking ahead and I'm thinking, well, where do I want to be in 10 years' time? And I'd probably like to be on that boat somewhere out in Barra. So it's certainly my interest that if I drop down to the complete hemiplegia there, what hope have I got really of you guys, somebody in the audience, picking up the skills and doing that for me? So I think we do have to think evidence is here, what should we be doing? Because time marches on, and I think we'll hear in terms of the cardiology interest and experience in relation to primary coronary intervention, it takes a long time to get from A to B. Do we want to be doing the same thing with this area? So thanks very much.
Thanks, Graham.
All right. I forgot my Santa hat.
Oh, no Santa hat, Graham says.
It's a shame.
It's a disappointment. The tension, John.
Well, it worked a little while ago.
I don't want it to capture. I want that.
Yeah, I didn't know.
Bum. Oh well.
Is it that?
No, that's the VGA one. You on HDMI.
I do have it.
Give me a sec. There you go. Is that better? Let's try that again. There you go.
And maybe we shouldn't draw out the analogies about fiddling around with things you have a limited understanding of. I'm going to talk about the development of primary PCI for STEMI in the UK because a lot of the logistical challenges for delivering a very time-dependent interventional service have been solved by cardiology, and it's quite interesting just how long it took actually. When you look at it, the proof of concept study was published in the New England Journal in 1993, when I was still at medical school. This paper described 142 patients, not an enormous study, randomized to either have angioplasty or streptokinase. They were technically successful almost always, and this was just with balloon angioplasty. And that arrived in what you couldn't really describe as fertile ground in the UK for delivering an interventional approach to myocardial infarction. In the mid-1990s, cardiologists were general physicians doing acute receiving and not really spending very much time looking after cardiology patients. There was typically a 2-year waiting list for cardiac surgery with approximately 10% mortality on the waiting list. Angioplasty was a very limited specialty. You were twice as likely to have CABG rather than angioplasty. Streptokinase was used before TPA, despite it being less effective. It was much cheaper, so that was what you did. The first series of ER showed somebody having an angioplasty, and I can remember people laughed at this idea of American exceptionalism that somebody should have an angioplasty for heart attack. Of course, they just have thrombolysis. That's what you do. So we have come a long way since then. This is the first maps, the 2002, but angioplasty was delivered in the big teaching hospital centres, and if you happen to live somewhere where there wasn't one nearby, then you were very much less likely to get intervention. What changed? Why could we develop interventional cardiology for a lot more people? Coronary stents changed. So instead of having a 2 or 3% risk of needing coronary artery surgery in the hours following your procedure, stents would reliably repair the dissections, and you'd have good flow. And emergency surgery is extremely rare, 1 in 5,000 now. You can see the increase in the rate of stenting from the mid-90s, when you had to have warfarin to try and prevent stent thrombosis, which tended to cause significant hemorrhagic problems in your femoral artery and didn't work very well. Stents were put in properly, inflated at high pressure, and we use them in most procedures now. And instead of taking warfarin to look after your stent, you take clopidogrel, and that works effectively with a low risk of bleeding. Another big change, we have to credit the fact that England led the way. The health secretary at the time, who was from the northeast, I think met Roger Boyle, and there's various anecdotes that you hear about this. But he was concerned about cardiology because one of his friends in his late 40s, early 50s, died on the waiting list for coronary artery surgery. And he went to see the consultant in Middlesbrough and said, how can this be that somebody who's, in the prime of his life dies waiting for an operation? And he said, well, we've got hundreds of people waiting for this, and there's just not the capacity to deliver treatment properly. And Roger Boyle was a district general cardiologist from York who'd been one of the first to develop cath lab in district general. And once you have cath labs, you get people getting properly investigated, and you can break down some of the cartels that form around the teaching hospitals with regard to protectionism, and numbers take off. So angioplasty has become more and more frequently used. It's more and more safe, more reliable, more predictable, and very efficiently relieves symptoms, and in some circumstances improves prognosis. So the ratio for the UK between PCI and CABG is reversed. It's 5.5. In Dundee it's about 7.5 PCIs to 1 CABG. And when it came to treatment of acute myocardial infarction, primary angioplasty was shown to be superior in multiple trials in multiple different circumstances. And this was collated in a study in the Lancet, not a formal meta-analysis, but it put all the data together, and this really changed the landscape. Again, it was multiple small studies, not quite 8,000 patients, but there were significant reductions in short-term risks of death, of stroke, particularly hemorrhagic stroke, which tends to be exceptionally disabling, and also, really importantly, recurrent ischemia. So a lot of people, when you've had thrombolysis, you've still got the lesion that's caused the trouble, and they're beginning to mobilise, they're beginning to recover from a heart attack, and then they have more severe pain, and the illness lasts for much longer if you leave the lesions there that's causing the problems. So people recover very rapidly from primary angioplasty and go home day 2 or day 3. There were trial centres in 10 centres in England, and it was shown to be feasible, reproducible, cost effective. There was a pilot project in Edinburgh in Scotland which showed the same findings, and nowadays primary angioplasty is delivered 24/7 across the country, and you only get thrombolysis if you live in somewhere really remote in the Highlands, or perhaps if you're presenting simultaneously with another case requiring primary angioplasty, and you might get thrombolysis if your procedure is going to be delayed. How sustainable is it? This slide always attracts attention locally. There are normally 5 of us. This is us here, I think. 1 in 5 doing about 750 angioplasties a year, 250 primary angioplasties. But for the last 4 months, we've been on a 1 in 4 rota. So here we are, officially the second busiest primary angioplasty centre in the UK. But it's sustainable. We're all still married. I've got some slides of the fracture to Stuart Hutchins' ankle, but we dealt with that. These rotas are deliverable if you look after the rota and make sure that you're not in clinic the next day or in the lab the next day. So, what's involved in primary angioplasty? Here's an angiogram. Here's a catheter that we floated up from the radial artery. Here's the left anterior descending artery coming down the front of the heart. Here's the circumflex wrapping around the side. Most of this artery is missing. Sliding a wire down through it generally is very easy when you've done it a few hundred times. Here's a catheter sucking out the clot, just a simple vacuum catheter. Here's some clot that you scoosh out into the collection basket, and every interventional cardiologist in the UK has got a collection of pictures of clot on their iPhone. They share. It's quite satisfying getting the clot out. There's the residual lesion. So if there'd been thrombolysis and the patient had reperfused, that would be left ready to cause another heart attack or angina. But you can put a stent in, and I mean it takes longer to describe this technique than it does to do it sometimes. It is really straightforward when it's straightforward. When it's difficult, it is more interesting. This patient has restenosed their osteal circumflex stent, and they've got a long segment of calcified disease in the proximal LAD, and they came in with ongoing pain. There's a bit of haze further down here, and it may be that he had a stent thrombosis. So this case started at about 6 a.m, I think, and I put a wire down the circumflex and a wire down the LAD. This is from a different angle, and ballooned open the narrow bit, and that made the circumflex a good bit better, but the LED occluded, and so he wasn't very comfortable at that point. But we've got a wire down already because we anticipated that might be a problem, and so we got a balloon down the LED and got some flow back. But it was really unimpressive, and patient's still quite hypotensive and ill, and we tried ballooning it a bit more, and you can see that there's a dent in that balloon there where it's just not expanding because there'll be a ring of calcium in the atheroma. So you just have to get out a bit more kit. This is the rotablator. So there's a drill bit that's 1.75 millimeters across, covered in industrial diamonds, that pulverizes all the calcium into tiny fragments, smaller than a red cell, that just wash down through the microcirculation and are removed by the spleen. And then you can put some big stents in and stretch them up, and that's it. So you don't have to do that most of the time. Most of the time it's easy, but you do have to have a bit of extra technique in reserve. In cardiology, we track our mortality, so each of these dots is a centre mortality. You can see that they're clustered around the mean. You can see that there's a few centres that are more than 2 standard deviations greater than the mean or less than the mean, which you would expect, but there's no real outliers. We also collect data in terms of the process, so call to balloon times should be less than 150 minutes to achieve results that are likely to be better than immediate thrombolysis. And not every centre can achieve that, but 9 mils has always been somewhere up here, above average. a lot of what you measure reflects the geography. So Freeman Hospital has a lot of smokers living in Newcastle, fairly close to the Freeman Hospital, but are also very well set up. So all of these data are available to make sure that the process is good. And we even publish individual operator outcomes, so you can go to the BSIS website and look at your operators' outcomes. So that it's a wee bit complex, but you can get a predicted freedom from MACE. So this operator, that's me, from the cases that I took on, predicting freedom from major events or complications, and mostly death, would be nearly 97%. In practice, the freedom from death was greater than that, but within the limits that you would expect from any sort of statistical modelling. So that's interventional cardiology at the current day. When it comes to stroke intervention, we know that the evidence is strong from small studies and dedicated centres. But in contrast to in the mid-90s, there are workforces that are available with the skills and a lot of experience in quite closely related procedures. And what the question really is, what would society find to have an acceptable learning curve? My view is that we don't have to be immediately as good as the neurointerventionists. We have to be better than what the current treatment is, which for somebody having a great big stroke is pretty awful, really. Taking a patient-centred view, how would I feel if in 5 years' time I have a big stroke and medicine hasn't got its act together to deliver a very effective treatment to it? And I think of the words of Jerry Adams when the peace process wasn't going so well. And, that's what I feel. We're not trying to solve Irish history. We're trying to deliver a little bit of aspiration thrombectomy. So I feel a bit more positive. I think Lennon and McCartney had it right. We can work it out. And in the email advertising the talk, Tom said that I might share some pictures, and I don't think it's stretching the analogy too great to share a little bit about the Archie's experience. This was instigated by Paul Fettis from Anaesthetics and featured a lot of medics and a lot of people from all walks of life working together to deliver a big, ambitious goal. And one of the things about working in teams when you're not familiar with people is developing the vocabulary and the language to disagree. And Tom pointed out to me that my sort of penguin-style waddle was very much the opposite of everything that he trains people to do in terms of running triathlons and things like that. And I thanked him for his insight. And I neglected to, or I declined to remind him of it 20 miles later when he was shuffling on straight legs with iliotibial bands like banjo strings downhill, and I was still rolling along quite happily. A better man might have not brought it up today. But I think you can work together and break down goals, and that was one of the great satisfactions of the Archie's Challenge, and I think that's one of the potential satisfactions of developing stroke intervention, because it will work. We just have to make it happen.
I'll just waddle over to the microphone. Thank you very much. He's a phenomenon actually on the mountains, and he left me for dead for the whole of the 2 days we're running, gentle undulating